So continuing on through our look through anatomy with motion as our central point of meaning or the central part of our semantic network, we're shifting now to the hyoid bone or motion of the hyoid and relationships to it. So we're not necessarily only going to talk about the hyoid muscles and the associated nerves and blood vessels. We're also going to talk somewhat about related glands as well as the tubes, right? I'll say the tubes for the more or less the pharynx, the larynx, the esophagus, and the trachea, and how they relate, especially to hyoid motion. So what we're going to do is a specific discussion of what hyoid motion is. So we're talking about elevation, depression, and retraction. And we're going to talk about planes and axes. Really what we're going to talk about is planes and translation, or movement in a straight line across a plane, because there isn't necessarily an axis of motion for the hyoid. You can argue this in different ways, but we want to bring this up as something that's at least mildly unique. So we're going to then have a specific discussion of the muscles that move the hyoid. And this is pretty simple in certain ways when we're talking about elevation and depression, but maybe not so much when we're talking about innervation. Blood vessels and blood flow, not too bad, but more or less the movement, the elevation and depression is pretty simple, but the innervation gets a little weird, at least with the suprahyoid muscles. We're going to have a specific discussion of relational motion of the hyoid, and that will be more or less contained within our discussion of planes and axes, or the planes at least, and translation, a general discussion of the neurovascular supply, as well as the related glands and tubes, and then a general discussion of the areas to assess and treat should hyoid issues or issues of related structures be reported or suspected. So when we talk about planes, we have already done this with the cervical motions, but we want to do this slightly differently. Okay, so the sagittal plane, just as a refresher, cuts the body left and right, or into equal halves left and right. The horizontal or transverse plane, equal halves top to bottom, and the frontal plane or the coronal plane, equal halves back to front. Now, elevation and depression of the hyoid could be argued to be translation in the frontal plane. So because it's back to front, it's a slide up and a slide down. So that would be in the coronal plane, but it's a translation in the coronal plane. There's no axis about which it rotates specifically, at least with respect to bilateral contraction of the infra and suprahyoid muscles. Bilateral contraction is going to be essentially translation, so elevation and depression translation in the coronal plane. Now, if there was for some reason unilateral contraction of one or more of the suprahyoid or infrahyoid muscles, you could have rotation, or really you'd call it side bending. Right, so side bending on an anterior posterior axis, right? So it's side bending or bending to the left and bending to the right in the coronal plane with an AP or PA axis. So that can happen, but for the most part, hyoid motion is going to be elevation and depression. So it is superior and inferior translation or elevation and depression. Now retraction, so the hyoid going backwards through active contraction, that would be more or less translation in the transverse or horizontal plane, right? So it would be straight backwards. Now, again, unilateral contraction, what you'd then have is rotation in the transverse plane or the horizontal plane about a vertical axis. So these are all possibilities, but what you're likely to identify if you're going to assess the hyoid on its own, really by basically holding onto it without choking the patient and sliding it across, that's usually where you're going to notice stuff. It's not all that easy to elevate and depress by a practitioner. It's much easier to slide laterally. So translate left and right in the coronal plane or the frontal plane. That's usually the best way to assess it. So you're not actually going to get a ton of information about elevation, depression, or retraction with patient active, because as they do it, you have to hold on to it to get some sense visually and in a palpatory sense. So it's very uncomfortable. So you're just not going to get that much information. So usually what you're going to do is slide it, right? So translate it left and translate it right, which is a translation in the coronal or frontal plane. You may be able to get a little bit if you hook behind it and pull it forward. So you may be able to actually test almost a rotation, but that's very, very uncomfortable. So really, in most situations, it's just going to be the translation left and right. So when we're looking at the muscles, we have basically the hyoid in the middle, and you're going to have the suprahyoids, or the four muscles above, and the infrahyoids, or the four muscles below. They're all pictured here, but two of them have essentially two bellies. So you're going to have the digastric as a suprahyoid muscle that has two bellies. So it's kind of going through a pulley that is a ligamentous attachment, or maybe a tendinous attachment. I don't remember the proper term because sometimes those get mixed up, but you've basically got a loop that it slides through, going from the mandible through that as a connection to the hyoid, and then back to the mandible. So it's almost mandible to mandible through a loop. So you've got two bellies on the digastric, and you have two bellies more or less on the omohyoid, because it has a tendinous portion in the middle that has also attachments to the carotid sheath, which we'll talk about a little bit later. But other than that, you essentially have your superior or suprahyoid and infrahyoid, right? The infrahyoid are often, as a group, termed the strap muscles, but there's people who will use that interchangeably for all of the hyoid muscles. For the most part, strap muscles would be the infrahyoids. So we'll break them apart and speak specifically to them with respect to innervation. So, and general motion. So the mylohyoid is the mandibular nerve, or V3, so cranial nerve 5, branch 3, the trigeminal nerve. So that's the mylohyoid. The digastric is the anterior belly is V3 again, or the mandibular nerve. The posterior belly is receiving motor tone from the facial nerve. So you've got a split between the anterior and posterior aspects as far as where they receive motor tone, but they can contract in unison should need be. The stylohyoid is the facial nerve again. The geniohyoid is the cervical nerve 1, or the anterior segments or segmental branches from the anterior primary rami. Some people would argue that this could be part of ansa cervicalis. Some people would note that it goes along with the hypoglossal. So there's a little bit of lack of clarity depending on source, but what you know that's clear and agreed upon is that the geniohyoid gets it from C1 and branches of the anterior primary rami. The mylohyoid and the digastric may contribute to some degree to depression of the mandible. And then broadly, all of them together will widen the pharynx to aid in swallowing. So while they can pull the hyoid up, they can also change the shape of the mouth. So when you're swallowing, as the tongue goes back, you can change the shape of the tube, or the top of the tube in the pharynx, before it starts to divide when you get to the larynx, and then you've got the division to the esophagus and trachea. But they can help change the shape to allow for swallowing to occur more smoothly, at least in that upper portion. So elevation, all of them, some of them, so mylohyoid and digastric, can help depress or pull down the mandible, and then generally, again, they'll all change the shape of the mouth or the orifice to aid in swallowing. They also, obviously, to at least some degree, and this includes the infrahyoids, aid in speech. So with movement of the mandible, aiding in movement of the mandible, that aids in speech, changing the position of the hyoid itself, as well as putting tension in varying ways on the larynx, as we'll get to, that will aid in the making of sound and the forming of sound. So the making generally, and the forming for communicative purposes. So these are all involved in speech. The infrahyoids, you have the sternothyroid, so that goes from the sternum to the thyroid gland. The sternohyoid, so from the sternum to the hyoid bone itself. The thyrohyoid, now this is the one that's weird for nerves, as with, I believe it was geniohyoid, where some will say just ansa cervicalis, some will say the cervical nerve 1, the anterior primary rami, or segmental branches, in concert with the hypoglossal nerve. So there's a little bit of lack of clarity again there for the innervation, but the thing that's agreed on is C1, or branches from C1. Now the omohyoid, essentially going from the hyoid to the thyroid, I should say clearly, goes from the thyroid gland to the hyoid bone. So it's able to move those in relation to one another. The omohyoid goes from the hyoid bone to the scapula, and it also has in its middle tendinous region a connection to the carotid sheath. Now, aside from the thyrohyoid, there's general agreement that all of these get motor tone from ansa cervicalis, which is from the cervical plexus. These all depress the hyoid, as well as depress and elevate the larynx itself. So the larynx is essentially the portion at the bottom of the pharynx as you get the branching to the esophagus and to the trachea, right? So for passage of particular things, particular substances, these are able to move the hyoid, put differing tension on the larynx, so open and close the larynx to some degree, and also aid in speech. So the position of the hyoid and the tension on the larynx. Now, the omohyoid does create pull on the carotid sheath. Now, the carotid sheath contains the common carotid, the internal jugular, and the vagus nerve. Now, because of specifically the internal jugular vein requiring a low pressure environment, the tension from the omohyoid can be argued to have some impact on the pressure environment for the carotid sheath itself, which would most likely have the greatest impact on the internal jugular vein. So if there is a mechanical problem noted with the hyoid and with the scapula, so they'd have to happen together at the same time, as well as an observation of blood pressure issues, especially on the venous side, then you have superficial information to say that there might be a mechanical relationship. So what you'd have to see is all of those. So you'd have to see the blood pressure reading, you'd have to see some form of dysfunction in motion of the hyoid itself, some form of dysfunction with the scapula, and then what you would have to see is after changing the motion characteristic of the hyoid and of the scapula, you'd have to see a concomitant change in the blood pressure on the venous side. So if you don't see all those things, the relationship is superficial at best, if not non-existent. But when you have all three of those pieces of information, you have something that you can point to create a hypothesis, right? So you can't create proof, but you can create a hypothesis or a prediction from those pieces of information. So it becomes an interesting specific muscle. So generally speaking, again, you have the depression of the hyoid, the elevation and depression of the larynx, which becomes important as far as the tubes are concerned, right? So the trachea, the pharynx itself, then the trachea and the esophagus as the branches. Now, the neural supply, so what we really have here is just a picture of the cervical plexus. So you can see the lesser occipital nerve, the antecervicalis. You can see the relationship to the internal jugular vein as well as the carotids, right? So as it ascends, as the external carotid ascends, the antecervicalis is in tight relation to that. What you don't see is the facial nerve and the mandibular nerve or the trigeminal nerve as it supplies the anterior belly of the digastric, as well as, if memory serves me, the mylohyoid. So I might have mixed that up, although previous in the video, I got it right because it's all written down. So if I made a mistake here, please just rewind and essentially catch me on it and clear up the confusion for yourself. The vascular supply, primarily what we're looking at is arterially the branches of the the branches of the thyrocervical trunk. So the inferior thyroid artery. Then we're looking at branches off of the transverse cervical to maybe some degree, but then we're just looking at branches mostly off of the external carotid. So the superior thyroid, as well as other branches to get to the muscles to supply to the hyoid muscles, supra and infrahyoid. As far as drainage, generally speaking, you're looking at concomitant veins, specifically the internal and external jugular. So you're just going to get drainage from both. Primarily where you would notice some form of mechanical dysfunction that may be impacting this, at least within the neck itself, would be the SCM muscle. Then generally speaking, ribs 1 and rib 2, the clavicle itself, or the neck generally. So there's a lot of areas that might impact the general pressure environment of the neck if there's a lack of motion. So all of that, these are all very similar. So once you get, again, above the clavicles, the areas for concern or areas for assessment and treatment are all very similar, especially on the venous drainage side and the lymphatic side as well, right? So the lymphatics, you're basically looking at dumping into so more or less traveling along the angle of the jaw, down the SCM, posterior to the clavicle, dumping into the subclavian veins on either side. So on the right side is the right thoracic, or the right lymphatic duct rather, so right arm, right side of the head and neck. The left side is the thoracic duct, so it's basically the whole body, but including the left side of the head and neck and the left arm, right? So those are stable. Again, nothing really changes once you get above, as far as supply and drainage are concerned, once you get above the clavicles. Now, as far as the pharynx and the larynx are concerned, so the pharynx, essentially, you're looking at space at the back of the kind of the nasal cavity, as well as down the back of the throat. So it's all kind of the posterior portion. So you have the nasopharynx, the oropharynx, and the laryngopharynx or laryngopharynx, depending on how somebody prefers to say it. That's where the larynx starts to show up. So the larynx is more or less the top of the trachea, so slightly anterior to where the esophagus would be, and it contains the vocal cords. Now, the oropharynx, or sorry, the laryngopharynx is responsible for essentially diversion of specific materials. So once you get into the oropharynx, or the pharynx in the oral cavity, what you're looking at is carrying, so the nasopharynx is all air. The oropharynx is air, water, and food. Once you get into the laryngopharynx, this is where you get the splitting. So up here, or up at the top of the pharynx, it's air only. The middle of the pharynx, the oropharynx, food, water, and air. Once you get to the laryngopharynx, you're going to have a split. Going to the esophagus, you're going to have water and food. Going to the forwards towards the larynx and towards the trachea, you're going to have air. So the larynx is essentially able to divert that with its function. So again, air only, food, water, and air. Once you get down to the larynx, it's diversion. So backwards to the esophagus, food and water. Forwards to the trachea, you're going to have air. Right. Now, as far as glands are concerned, you're going to have the thyroid gland more or less hanging from the bottom of the hyoid and the cricoid cartilage. So you have it hanging below. So if you're able to identify the hard part or the bone, which is not the easiest, it's actually a lot higher than you think sometimes. Depends on the particular individual, but it's often the hyoid's higher than you think it's going to be. But hanging off of that, underneath on the cricoid and the thyroid cartilage, then what you're going to have is a thyroid gland. The thyroid gland is basically responsible through T3 and T4 for basal metabolism and temperature regulation. It also has some impact on cardiac function to some degree through metabolic pathways. So, and also it is going to be responsible for some form of balance for calcium in the blood through calcitonin. So calcitonin, if memory serves, calcitonin pulls, I believe calcitonin pulls blood out of the blood and tries to store it in the bones, whereas parathyroid hormones, so the parathyroid glands are on the back of the thyroid, so they're somewhat protected, but usually have four little circles on the back, and that's going to release parathyroid hormone, and parathyroid hormone is going to increase calcium in the blood. So it pulls more or less calcium from the bone and puts it into the blood. It's also responsible for serum phosphate, if memory serves correctly. I may be incorrect on that, and that can be checked easily. This is an online resource, so if I'm incorrect, feel free to check. But I believe it's serum phosphate. So you've got this balance of calcium between the thyroid and the parathyroid within the bloodstream. So it's got diffuse effects on the body, and then you have diffuse effects through metabolism, more or less through the thyroid hormones, and then you also have some impact on phosphate. All right, so as far as areas for consideration for assessment and treatment, so the sternum itself, so the sternohyoid and the sternothyroid. So if the sternum's not moving appropriately and the hyoid's not moving appropriately, you can work on either end and maybe have some impact on those particular muscles. The SCM, generally speaking, so the SCM, you're thinking about relationships with blood supply. You're also thinking about a relationship to some degree with the carotid sheath and the omohyoid. It's not necessarily going to have a gigantic impact on the hyoid bone itself or its ability to move on account of the fact that there's so many muscles there, but there may be some relationship. But the relationship with the SCM, if there is a change in the pressure environment, changing something, especially about venous drainage to the head and neck, you may have some impact there. The neck, generally speaking, so if the cervical vertebrae are not moving evenly, then you can suspect that there's going to be some tension, uneven tension through the hyoid musculature. The mandible and the TMJ, largely on account of the connection to the suprahyoid muscles, all more or less connecting to aside from the stylohyoid, to the mandible itself, and the hyoid, as well as alterations in the pressure environment, especially on the venous side. If such a relationship does exist, it often doesn't, but it's worth considering. The scapula, now the scapula being related primarily to the omohyoid as an individual muscle, but the scapula also changing tension on things such as the trapezius and levator scap and putting variations in tension through the neck, especially as large muscles and large structures. The hyoid itself, so again, translation of the hyoid, you're not going to move it up and down well. You're not going to move it forwards and backwards well, even bilaterally. It's just not comfortable. It's very, very sensitive there. Now, generally speaking, superficial complaints or superficial signs that there may be reason to consider the hyoid as far as patient report or patient presentation. Issues with body temperature. So if the patient's talking about their temperature always running high or always running low, or really not necessarily always, but more so a quick switch. It's like I'm usually hot, but now I'm really cold. It could mean a lot of things, but if it is not extremely drastic and seeming heavily emergent, like you need to refer them to emerge, like such as if they're in shock, so they're always running warm, but now they're really cold, and there was a recent traumatic event, then that's probably shock. But if there is maybe within the last 2 days, they feel really cold and the weather wouldn't suggest that, then maybe something really dramatic has happened to the thyroid. It's possible if they're usually on the colder side and they get really hot, again, a fairly quick change that doesn't relate to trauma, you can at least consider the thyroid gland, but it's not likely to happen. This is not a likely presentation, but it's a consideration, even if it's only for awareness. Recent rapid changes in weight, right? That without any other explanation, that could refer to a lot of things. So it could usually really fast drops in weight are something larger than just the thyroid, and sometimes gain in weight could be other things, but it could be the thyroid. Again, it's a consideration. It is not proof of anything, but it's a consideration. So if you see something like that, then you can consider the hyoid as maybe playing some mechanical part, but again, it is not likely that a major change in weight up or down is going to be because the hyoid isn't moving right and is impacting the thyroid. It doesn't mean it's not a part of it. It's just not likely to be the big deal. And then any issues with bones, right? So heavy, like, really thick, dense bones or odd bone growth. It's possible that the thyroid isn't doing its job. The thyroid and the parathyroid aren't playing off of one another properly. Anything along the lines of bone resorption issues, it's possible that there's an imbalance there. It doesn't mean there is, because it also does seem to be a normal feature of progression through life is changes in the bone. But really, really notable things. It's worth considering the hyoid and the muscles that relate to it. So the super and infrahyoids. Again, it doesn't mean that something's going on there, but it's worth consideration. Most of the patients with these particular complaints are not coming to an osteopathic manual practitioner with this as their primary concern. It's usually going to be a pain concern or a movement concern, but every once in a while, if it seems like something is strange that isn't being addressed appropriately, you can refer out, right? So if there's issues with body temperature, recent rapid changes in weight, or issues with bones, you would choose to refer those out. You can, for your own edification and hypotheses testing, check the hyoid itself, but you're not likely to find what you want to find. You're more likely to figure out that you should refer this person out to a higher level of care that can do a deeper level of diagnostics. But again, because of the way that these structures relate to each other, it's worth a consideration, but it's not likely to be that the hyoid isn't moving. So you have systemic weight issues or systemic metabolic issues or systemic temperature issues or changes in the bones, right? That's probably not what's going to go on. What's more likely to go on is that there could be an issue with a mild issue with swallowing, changes in the voice itself, right? So changes in the ability to control the voice are more likely to be identified from the hyoid and the tone of the muscles, more so than changes in body temperature or weight. So more likely than not, the concerns that you're going to be able to deal with are mild issues with swallowing. Large issues with swallowing, you got to be really careful, because that could be a cervical disc bulge. It could also be very, very dangerous. But changes in the voice, especially for people who use their voice as a tool or an implement, this work or the work on the hyoid may have a more positive impact.